I'm co-chairing with Paul. I'm just going to start with a 5-minute run through what's been going on this year in urology. So the session today is really about training, which we all think is the key to what we're trying to do. And we've got two excellent speakers, and I'm really excited to hear their talks on different angles on this. So what have we been up to this year? As you're aware, we've got 3 project sites which we focused on, but as I've said many times, there's lots of other good stuff going on around. But just to update you on the project sites. So Hawassa in Ethiopia is absolutely flying at the moment. Getch has come back from training. They're now doing TURPs, and this is a really exciting publication which shows for the first time that they're doing more TURPs than they're doing open prostatectomies. He also went off in January with Graham Watson to Sri Lanka to train in PCNL and stones. For that reason, there wasn't a urethroplasty workshop, and there is going to be one later in the year. Their aim now is to become the second centre for training outside Addis in Ethiopia, and I have absolutely no doubt that they will achieve it. So really exciting, really good, and thank you very much to the BJUI for their financial support for this project. Lusaka in Zambia, again, John Cartledge went in March, I think, and he's signed them off for doing TURP. Generally, the theatre teams, Paul went in May, and generally the theatre as a team structure is much, much improved from when we first went there. And that was helped a lot by Jerry, who went out with John Cartledge. But yeah, generally they've got new staff and teams much improved. So we've asked them now, really, so where they want to go from now, and they would like to also develop endourology, so that needs to be our next aim. I'll talk about the leadership in a minute. KCMC in Tanzania in May, Asan Chowdhury went out. Just to go back to thank TUF very much for their support of Zambia. Our funders have been amazing, very, very tolerant. It's all taken a little bit longer, as you'd expect in Africa, to get things done, but we are getting there. So KCMC, Asan Chowdhury, who works at Bedford, I don't know, are you here, Asan? Went out in May, and they did the first PCNL in Tanzania. So Olympus had donated kit, and so that was really exciting. It went really well, and we really just need to think how we can support them moving forward to get up and running completely. So again, KCMC probably really doesn't need a lot of our input anymore. They're training others in Africa, predominantly now more Tanzanians, actually, as each of the other countries starts developing their own urology program. Phil Thomas and I went out to Cosexa in Mozambique, which we helped with the exam. So they had MRCP on a Monday, and then on the Tuesday, FRCS. We examined the urology section, and we had 5 people, and we passed all of them. So we then spent the next couple of days at the annual meeting, which was a really good networking, starting to have good relationships with lots of our colleagues in East African countries. So that's excellent. That was our 3 generations and 3 continents of urology women. So finally, just where are we going from here? I do think we probably have a capacity now to take on other centres, and I think you may have seen, hopefully everyone's been to the Boston stand, because they are donating £10 for everyone who visits to Urolink, which is really exciting. So if you haven't been, please can you go and put your little blue thing in to support. We're hoping that that money will go back with Charles, who's going to talk to you in a minute, to Malawi to get a generator so that he can do TURPs. And equipment continues to be the biggest issue. There were some very exciting talks from the Netherlands about this, and hopefully we'll move on a bit later in the year. The other thing we've identified is the need for leadership training in these countries, and in fact I've been pushed by my husband, who's an anaesthetist, into running one at our hospital, which sells itself as for its leadership development stuff, and that's going on in October, and I'll feedback on how that goes. So there's 2 urologists going on that, 2 anaesthetists to start with. And again, another thank you to the BJUI, who have very generously allowed all the trainees in our project sites to have access to BJUI knowledge, which is another great initiative. I will now hand over to Charles Mabibi, who is, I first met at KCMC, where he was training there, then at the exam 2 years ago, and now I'm lucky enough to have him we're lucky enough to have him working with us as an IMT graduate for 2 years. He was not very popular because he is the first urologist in Malawi, so there's now nobody there. But hopefully he's going to gain lots of skills and take them all back to Tanzania over the next year. Charles.
Thank you very much for this opportunity to Urolink. It's a great pleasure to be here today. I'm going to talk in the next 15 minutes on why we need urology training in Africa, what training exists, the challenges and possible opportunities as well. For those who are not familiar, I come from Malawi. It's a country in the southern part of Africa. On your right, you can see how it compares to the UK in size. Just slightly smaller than the UK, but certainly the weather is warmer and more predictable in Malawi. A lot of people in Malawi, 18 million people. We have a health system that's funded by government, and historically, most of our urologists have been coming from outside to serve in Malawi. And possibly that's why I'm involved in all this, that for a long time we've never had Malawian urologists. And most of the work is done by general surgeons and other cadres. Some 8 years ago, I got inspired to make a difference. This would be a typical patient coming in with obvious acute retention. He hasn't been peeing for a few days. And his main plea was, "Doctor, make me pee again." And that made me think that maybe we could make a difference. And I thought by becoming a urologist, I could make a difference in Malawi. So I looked at why do we need urologist training in Africa. Basically, it may sound obvious that we need training, but in Africa, there's a lot of understaffing. If you look at the 2015 Lancet report on the global surgical workforce, combining surgeons, obstetricians, and anesthetists, you'd see that Africa is understaffed. Basically, on this map, the paler it is, the less understaffed it is, the less staffed it is, and the greener it is, the more people are there working. And to put this in perspective, 2 years ago, here in the UK, one urologist was looking after 60,000 patients, but in East Africa, one was looking after 400,000. And we're still in Malawi. At the moment, one urologist looks after 9 million people because we're 12 of us. And that ratio now is just worse than it was. It's just now 1 to 18 million people. Secondly, there's a big unmet need for urological surgery. A lot of people wait for urological surgery for ages. This was a patient who came in with an acute retention because he had a stricture, but he'd been living with a long-standing hydrocele for ages. And sometimes sounds funny, but there's this classification that growing masses in Africa are classified into two. So scrotal masses, there are those that are above the knee and those that extend below the knee. Obviously, this is above the knee, so this is not the worst hydrocele you can see in Africa. We also have a lot of advanced disease. This was a patient we saw last year with squamous cell penile cancer presenting for the first time. And sometimes before you do anything to these patients, you have to think within yourself, if you're going to do good by operating on these patients. Certainly, you want to take out the tumor away from the patient, not the other way around. And a lot of things in Africa are done open, and this includes even procedures which ideally should be done endoscopic, like bladder neck incision sometimes are done open because it's just not possible to do it endoscopically. So, having looked at the need of urologists in Africa and why we need to train them, I would like to shed some light on what exists in Africa. So the two main training programs, the first one is university-based training, which is it's in-country training programs. Most of them are 4-year programs. At the end of that, you become a urologist, and in most countries, you'd get a consultant post after that. There are also fellowships, which is 5 years. In the western part of Africa, there's WACS, and the eastern part of southern part of Africa, there's COSEXA. I did my training under COSEXA because that's what was available in my country. Started the 2 years in Malawi, and then I had to move to Tanzania because there wasn't any fellowship training for COSEXA in Malawi. COSEXA is fast growing, and the number of centers offering urology training are also growing. That map shows the membership for COSEXA. All the trainees sit one exam, they do one curriculum, but they're trained in different places wherever they are. So I moved on to Kilimanjaro Christian Medical Center in Tanzania, and Susie had mentioned that already, but it's a beautiful place just at the foot of Kilimanjaro mountain. It's one of the biggest and oldest centers with huge numbers of surgery. I'm not sure if there's any other center doing more endoscopic surgery in the region more than Kilimanjaro. And it's also well accredited to train. Because it's so popular and well known, we have trainees from all over the region. And the good thing is that because in Africa there are not so many urologists, I've been able to even train general surgeons to provide urology care. So they have different programs, certificates, diploma, M.Med, and obviously they also offer COSEX training, depending on the need of the surgeons. Obviously there's some challenges in this training, and you may notice that I've put them in small font because I believe they can be overcome. The first one is building a team of trainers. In most African countries, you'd have isolated trainers who are willing to train, but they're not all supported with a good team to train people. Second thing is obvious equipment for training. In some places, basic equipment for urological surgery, like in Malawi, is a problem. And in some places where they have that in place already, like Kilimanjaro, what they need is more another step forward, which is more imaging and CM. The other challenge is that training is not always popular. Personally, I also had this. It was difficult to convince my hospital administrators to let me come for this fellowship because they see it as one extra pair of hands taken away. But the bigger picture is that if you have someone who is all trained and can train others, then you can make more difference than a surgeon treating individual patients on an everyday basis. Also, sometimes trainers feel that training doesn't pay because the jobs they're employed to treat patients, not necessarily to train students. So sometimes trainers may not be motivated enough. Finally, trainees need funding to do their training. In most countries, we don't have set jobs like you have here where you have a paid job when you're doing training. So trainees have to pay their school fees, have to support themselves, so sometimes it's challenging. Fortunately, I was lucky I got a scholarship when I was training, so I didn't have to worry about paying fees and all that, but it's not always easy for the trainees. Beside these challenges, there are always opportunities. And I feel that the biggest opportunity is that there's always be patient and there's a big demand for urology in Africa. Secondly, we've seen recently a high retention rate of surgeons within the COSEXA region, and I'm proud to say that in Malawi there's 100% retention. We're not many surgeons in Malawi, but a lot of people are staying, which is a good sign. I think a key now would be encourage those that are staying to keep staying rather than leave. I think there's also an opportunity for collaborations. Before I came here, I'd never done a flexible cystoscopy before. So this was my first time to do it here in the UK. But I also understand that the trainees here in the UK who've never done an open prostatectomy before. So it's opportunities for exchanges as well. At the moment, I'm on the Royal College of Surgeons Fellowship kind of training, so that's also an opportunity for us to exchange ideas and skills. The other opportunity we have is that as we train and more and more fellows and more people graduate, there's hope that we can have more trainers. We just need to motivate them so that they can form a good training team. Moving forward, I think in the future, local training in Africa will become more and more established because, as I said earlier on in the beginning, before it was people leaving Africa, coming to train here and then going back, and then some were lost in the way and some remained. But I think in future there will be more people training locally, and we hope that they will stay. There are also more centers that are being set up, and I'll come to that in a moment. And I believe all these small challenges that I discussed before can be overcome. So when I finished training in December 2016, I obviously returned to Malawi, and I had a chat with other consultant who's been working there for a long time, more than my age actually. He's not Malawian, but he's been in Malawi for a long time. And we agreed that we should never send people outside to do basic specialist urology training. So we managed to work hard in 2017, and we were accredited to train urologists in our hospital. This is the first hospital in Malawi to get accredited. Under a 5-year program, and we've started taking 2 students every year. The first trainees will be joining us in August, and we hope that we can develop a strong team to give better quality training to our trainees. These pictures just shows the progress we've made. On your left, top left, this is some 6 years ago. That's the kind of theater we had. But with some support from Norwegian government, they have rebuilt the whole thing. So what you see on the left, on the right bottom, is a complex of theater and surgery, teaching annex, and obviously offices. This is 2 weeks ago. I couldn't take a picture of the theater inside because I know you're interested, so I want you to see it for yourself when you come. And finally, apart from treating all the diseases in Malawi, Malawi is a warm heart of Africa, so I invite you to come. Beautiful beaches, big freshwater lake, one of the biggest in the world, and lots of species for fish. Thank you very much for your attention, and feel free to get in touch, and if you're interested, we can always collaborate and work together. Thank you.
Okay, it gives me great pleasure to introduce the next speaker, Abubakar Jar. He's a very accomplished surgeon in his own right, and I'm very lucky that he is presently my fellow. I'm certainly learning an awful lot of stuff from him. He was actually a BJUI scholar for about 3 years and worked on the South Thames rotation. And now he is the only urologist for the whole population in the Gambia. And I'm trying to train him up in urethroplasty, which is it's going very well, actually. Over to you.
Well, thank you very much for that introduction, and thank you for the opportunity to give this talk today. The objectives of my talk are to highlight the needs and challenges of urologic services in low, middle income countries, but I'm going to concentrate on Africa, especially sub-Saharan Africa. My colleague has brilliantly given some idea of what is going on there. The second objective is to enumerate the potential impact of training urologists for these countries, and to understand the role of visiting urologists, example Urolink, and also to suggest efficient modus operandi for training these urologists in the UK. My colleague here has given you all the reasons to know that there is poverty of all sorts of resources in Africa, human, material, and infrastructure. In the EAU meeting 2015, it was highlighted that there was lack of urologists and there was insufficient proper training of urologists in our region. He has also given, I mean, I did not put Malawi here, but it's even worse than the Gambia, where we have one urologist for 2 million people. They have one for 9 million. In Nigeria, is 1 per million approximately, while in the UK you have 16 urologists per million population. My colleague has also mentioned these two colleges. The West African is the older of the two, established in 1973, while COSEXA came about only in 1999. So the question is, why should UK invest in training urologists to work in low and middle income countries here in the UK? I'm going to convince you that, or try to convince you that that is very useful by giving a case study of my own situation. I won the BJUI scholarship in 2005, having passed my West African College of Surgeons Part 1 exams, which is equivalent to the MRCS or registrar level, or senior registrar level actually there, because you have 3 parts of the exams. I did the rotations and completed it in 2009, having gone through several hospitals. And I think, apart from all these things listed, that I have come across and worked with people who did these things and learned from them. One of the things that impacted my training most is clinical governance, knowing who to operate on, why to operate, and all the clinical governance issues that are not well established in the training in our regions. There are benefits for training people like me and my colleague in the UK, because when I did the rotation, I did it pretty much like any other UK trainee. I was not, there was no difference whatsoever. Provided service to the NHS, provided on-call covers, which are becoming a big problem at the moment. And then even after the training, I had opportunity to come and help in some hospitals on locum basis when they were struggling with staff cover. The benefit to the home country where I come from are immense. You take new skills. I did a lot of green light lasers, but obviously that's not coming very soon in the Gambia, and it is actually phasing out here. But laparoscopic surgery is very important, and we are starting a new center in my hospital this year. With the exposure that you have here, you become more confident to do cases. This is a young boy, I think he was 10 or so, who had this huge swelling for many years and was just told that this could not be done in the Gambia and it's probably malignant. I saw him, reviewed the CTs, discovered that it was not malignant at all. It was just a polycystic kidney, removed it, and this was him afterwards. This is a gentleman talking about scrotal lesions being below or above the knee. This was below the knee for 20 years, could not do anything, reduced mobility, did a scrotectomy for him, and this is him after the surgery, doing very well now. We are now doing the fistulas for the what do we call it again? For the kidney disease patients going through dialysis. It was not being done in the Gambia before I went back, and we're doing them now successfully. I've done 4 penile implants there. Unfortunately, one of them, who was a diabetic, developed infection and it had to come out, but all the other 3 did very well. One of them coming actually all the way from Nigeria to the Gambia to have his implant done. We have to be innovative. This is a psychiatric patient who slipped his penis into a very thick ring, came to us, so we had to use very elaborate equipment to get it out, and that's the ring out, and this is what we used, which was from the carpentry department in my hospital. Sometimes they come very late, and I usually describe the Gambia or countries in my region as a museum for natural history of diseases. And you see things in very late conditions and you can't do anything about it. What we can do is to give public health education, and I'm involved in that in the radio stations, in the TV stations, and even in the paper media. We are also involved in transfer of knowledge to residents in the hospital, to medical students. I'm a lecturer in the university, and also examinations. Some of you may recognize a face here of a Gambian urologist working in the UK who comes as an external examiner here, George Fowlis. You have to be able to improvise. We, at some stage, did not have 3-way catheters, and after a TURP, that's a 2-way 18 French catheter, and I had to slip an NG tube alongside the catheter to be able to irrigate the bladder after the TURP. This is Graham Watson, and you can see what he's done to his lead, because there was no lead protecting only his vital organs when he was doing PCNLs with me. TURP was a big issue when I went back. We were using distilled water during the Urolink trips. There were some problems with TUR syndromes and lysis of red blood cells. So I started using glucose, and because the glucose bags are only 500 mils, I improvised this container which can give me all the fluid I need, 12 liters, to do a whole TURP without stopping. And with the big prostates that we have in this region, this has been very useful, and I presented in a conference recently for WACS, and it was well received. This is another one that was improvised by Graham Watson, and we're using saline, making our own saline to do saline resection in one of the hospitals. Humanitarian services are essential, and I'm also traveling abroad to different countries doing fistula surgeons, VVF, vesicovaginal fistula. And this is Paul Anderson and I in Zambia very recently, where we had lots of, should I call it, adventures. And we did lots of operations, and it went very well. Collaborations are very important. After finishing, I worked in Royal Derby Hospital and had a very good stint with Stephen Thomas, and they were going to get rid of their stack, and they sold it to me because of lots of bureaucracy at £1, and it's gone back to the Gambia, and it has done lots of endoscopic surgery, saving lots of lives. And this is also another thing that can happen. Unfortunately, the NHS has become very strict on this, and even things that are not being used, it's very difficult to get to the right people under the circumstances. These are just some of the benefits that I have mentioned previously. One of the potential disadvantages is brain drain. When I came and did my BJUI scholarship, after finishing, there was nothing binding me to going back to the Gambia. And I could stay. I had lots of offers to stay and work. So that's a potential problem. But I think we can work through that to make that unlikely to happen. And also, we cannot just conclude that anybody who comes in will have the same type of success that I had in the training. So we have to be able to select very well the people that are coming over. Just a quick 2 slides on the role of urologists. I did an audit of 10 years Urolink in the Gambia, and as you can see, lots of work done at that time. None of these was possible. Now, most of them are possible there. But apart from the surgeries that are done, there's transfer of knowledge, identification of potential trainees. I was identified by the Urolink team in 2003, 2004 that I would be able to benefit from training here, and that can go on. And then also continued collaboration. It becomes much easier when you have somebody there for collaboration to continue. So I'm recommending the following, that Urolink, in collaboration with partners like BJUI, like the GMC, like even the Home Office, to set up a method of bringing in trainees regularly from these countries, and also to set up methods of supporting them after they've gone back home so that they can do what they were trained to do. It's a worthwhile investment, and if every 3 years after I finished in 2009 we had another Gambian coming in to do such a program, by now we would have 4 urologists instead of 1 urologist in the Gambia. I would like to, at this juncture, thank all the people who have made this possible. I think there is Sam McClinton here who received the gold medal yesterday, so I'm very proud. We met in 2003, 2004 when he came to the Gambia, and we did lots of work together. George Fowlis, who is a Gambian urologist, has been very instrumental in making that possible, and still goes to the Gambia under the Urolink to do some work. So I thank you all for your kind attention.
So we have a few minutes, so are there any questions for either of our speakers? Thank you both very much, really interesting talks.
Hi, thank you so much for such an inspirational talk. I just want to know, what are the opportunities for UK trainees doing an exchange program? Because as you've mentioned, there is a lot to be gained for both the UK trainee and for doctors in the Western country.
Is it for me? Thank you for that question. Actually, when I went back home, since I went back home, I've had 2 trainees. One of them was a younger trainee who I met in Derby, who came to me just to get his hands dirty on open cases. And I was able to do, within a week, about 6, 7 open prostatectomies with him, Millings prostatectomies, and some other open cases with him, and he was very happy with that. He's now a urologist, and there is another gentleman who came with the Urolink also. So there is lots of opportunity. And I think on my last slide, it should come on, there is my email and everything. Anybody who wants to get in contact, we can arrange that.
Thank you.
We do try and include trainees on all of the trips that go out, and in fact this year we have got one trainee who's having a whole year out of programme experience, so he's been to all of the centres. I'm sure he will present to us next year. So there are opportunities to go with the trips.
Great presentations. Just a question to both of you really, but what do you see as the sort of burden of urological disease in Africa in looking ahead to the future, the next 10, 20 years? Where does the training need to be most focused?
I think currently the top 3 would be BPH strictures and possible oncology, bladder cancer, prostate cancer. I think that's what we need to focus at the moment, and then move further from that. The other conditions like erectile dysfunction, which would be thought to be more of quality of life things, are usually lower on the list of that ranking.
Okay, well, thank you very much, everyone, for attending.